Yes. Am I audible, sir?
Yes, please start.
Yes. Good evening, everyone. Today, reach how to approach a critical congenital heart disease and how do we who are early diagnosed with critical congenital heart disease. Let me start with an case history. 33-weeker male baby delivered by a spontaneous vaginal delivery with a birth weight of 1940 grams. Baby cried immediately after birth. Abgas were normal. Followed the delivery, baby developed respiratory distress immediately after birth with a SA score of 5 to 6. Saturation at room air was 87% and respiratory rate is 80 with severe intercostal and subcostal retractions, and heart rate was 146, and baby had bluish discoloration of lips, face, and arms and legs. That is, cyanosis is there. No obvious external congenital anomalies were seen. When it comes to the systemic examination, cardiac wise, S1 S2 heard, bilateral air entry present, but abdomen was soft, and baby was a dull, lethargic. With this background, if we go with a case of, to brief, 33-weeker with 1940 grams, male baby delivered by spontaneous vaginal delivery with a respiratory distress. So with this background, if we have a history and we proceed, so main here we have two things. One is cyanosis, another one is respiratory distress. So cyanosis, what is cyanosis? The bluish discoloration of skin mucous membrane caused by an increased concentration of deoxygenated hemoglobin. That is, deoxygenated hemoglobin exceeds more than 3 to 5 gram per dl. Then we can see the bluish discoloration of skin mucous membrane. This cyanosis, we know that there is two types of cyanosis, that is peripheral cyanosis and a central cyanosis. Morely, we talk about central cyanosis. So most common causes of cyanosis or central cyanosis mainly are cardiac or a pulmonary causes. Cardiac, yes, it is a congenital heart disease in a newborn, yes. Next, pulmonary. Pulmonary, we know, or any pulmonary disease or pulmonary pathology is divided into 4 types, that is parenchyma, airway, extrinsic lung compression, and hypoventilation. Parenchyma per se, we have in a newborn is meconium aspiration syndrome, respiratory distress syndrome, pneumonia, atelectasis, etc. Whereas in case of airway, that is, an airway includes anal from the tip of the nose, that is choanal atresia, tracheal stenosis, laryngomalacia, all the airway obstruction causes. Extrinsic lung compression, which includes pneumothorax, pleural effusion, diaphragmatic hernia, etc. Hypoventilations like neuromuscular disorders or sedation, sepsis, all this can cause towards the pulmonary and causing cyanosis. The other cause of the cyanosis is persistent pulmonary hypertension. Then the other includes abnormal hemoglobin. We know methemoglobinemia. Peripheral cyanosis will be seen in newborn in cases of like hypothermia, hypoglycemia, polycythemia, neonatal sepsis. All this can cause peripheral cyanosis more predominantly. Of breathing is predominant compared to that of the cardiac cause. The work of breathing predominant. The scores like Downey score in a term baby or Silverman score in the preterm babies will be high, that is more than 6. And whereas cardiac cause causing the respiratory cyanosis with the work of breathing will be less. Like there could be a mild tachypnea, but the retractions part and the score part will be more, will be less, like 1 to 2 or 2 to 3 will be the maximum. Whereas cyanosis part, cyanosis in the respiratory cause, the work of breathing will be high, cyanosis will be a mild. Whereas in cardiac, the cyanosis is predominant compared to the work of breathing. The final thing is hyperoxia test. The response for the hyperoxia test in case of respiratory is good, whereas in case of cardiac is not that good. So what is hyperoxia test? Administration of 100% of FiO2, then recheck with the PaO2 by an ABG levels. If the PaO2 is more than 300, then it is normal. If it is between the 150 to 300, then it is a pulmonary disorder or could be CNS disorder or like a methemoglobinemia. In between 100 to 150, if the PaO2 levels, then it comes to the PPHN or cardiac mixing lesions with increase in pulmonary blood flow. So less than 100 typically seen is in conditions like cardiac condition with parallel circulations like TGA or cardiac mixing lesions with restricted pulmonary blood flow like pulmonary atresia or tricuspid atresias. So here comes the cyanosis. Yes. Then do with the hyperoxia test. Yes. Hyperoxia. There is no response with the hyperoxia test. Yes. Most probably could be the cardiac cause. So then we different how to differentiate between the cardiac cause. Like what is the cardiac cause causing the hyperoxia is bad is one is PPH and another one is cardiac congenital cardiac disease. So how to differentiate between these two is, so hyperoxic hyperventilation test. What is hyperoxic hyperventilation test? Give a mechanical ventilation connected with a 100% of FiO2 with a rate of 100 to 150 beats per minute, like bypassing it. So in that conditions, if PaO2 increases more than 100 mm of HOT without hyperventilation, then it is a pulmonary parenchymal disease, we know, because pulmonary pathology without hyperventilation, yes. If PaO2 increases at a critical of PCO2 of often less than 25 mm of Hg, then it is PPH. That is the pulmonary hypertension is causing. When there is no increase in PaO2 despite of giving hyperventilation, it is a cause of nothing but critical congenital heart disease. So here comes central cyanosis. Yes. So here pulmonary cause and cardiac cause. Okay. Pulmonary cause, the most of the thing, work of breathing and cyanosis. Next comes with the hyperoxia test. If the hyperoxia test improved, then it comes with the pulmonary causes, like respiratory causes. If the hyperoxia test, there is no improvement, go with the hyperoxia hyperventilation test. If there is an improved, then go with the PPHN. If there is no improvement, then go with the echo, which finally diagnosed with as critical congenital heart disease. So here comes clinically, we get an approach for a critical congenital heart disease. So in the index case, if I go back to the index case, with this background, we have done a blood gas with a pH of 7.27, PCO2 of 49, PO2 of 45, and bicarbonate of 18, and lactate of 1.8. So X-ray has been done at this time, and X-ray was showing ground glass appearance bilaterally. So now, if we think of possibilities, the preterm with respiratory distress and X-ray was showing ground glass appearance this way, what could be the possibilities? The first possibility as a neonatologist we can think is respiratory distress syndrome. So respiratory distress syndrome, it could be a bilateral pneumonia or air leaks, pulmonary hypoplasia or pulmonary malformations, pulmonary edema, or pulmonary venous hypertension, and finally could be the cause of congenital heart disease. So how did we manage it out? So we intubated and ventilated the baby on SIMV mode with a PEEP of requiring the PEEP gradually from the 18, we have increased till 26, PEEP of 7 and FO of 100%. In view of high requirement of pressures, first dose of surfactant was given at around 2 hours of life. Ventilation was escalated to HFO in view of high pressures. And then at 7 hours of life, still requirement of HFO, second dose of surfactant was given. Hypoxia was still persisting despite of 2 doses of surfactant, and dope has been ruled out. Then next comes with the diagnosis. Next comes with the thought of high ventilatory requirement and hypoxia. 2D echo was done, and then this showed supracardiac obstructed TAPVC. So supracardiac obstructed TAPVC. What is TAPVC? Is nothing but critical congenital heart disease. Why I have taken a topic to a specific of critical congenital heart disease is, first of all, what is critical congenital heart disease? It's defined as a lesions requiring surgery or a catheter-based intervention in the first year of life, then it is called as a critical congenital heart disease. So what is the use of it? If we diagnose in an early diagnosis and timely management, the risk of morbidity and mortality will be very, very, very decreased. Almost 60 to 70% of morbidity and mortality is decreased if it is an early diagnosis and timely management has been done with the critical congenital heart disease. So what is the incidence of critical congenital heart disease? Overall, the incidence of congenital heart disease approximately it is around 10 per 1,000 live births. In that congenital heart disease, almost 1 in every 4 babies born with critical congenital heart with a heart defects as a critical congenital. Almost 25% of whole congenital heart disease is critical congenital heart disease. So in a broadly way, how do we classify critical congenital heart disease? Is duct-dependent pulmonary blood flow, duct-dependent systemic blood flow, parallel circulations like TGA, and others like TAPVC or TAPVC obstructed TAPVC. So so how do we approach? Here comes. So approach starts from the antenatal and natal period. Yes, antenatal and natal period, then clinical presentation or the clinical examination, and by a bedside diagnostic tool like pulse oximetry, chest X-ray, ECG, echocardiography. First comes with the antenatal or natal. Do we do all the antenatal mothers are going with a fetal echo? No. Only few of the mothers having so and so indications will go for a fetal echo. What are the main indications? The maternal indications include first degree relative with congenital heart disease or metabolic conditions like uncontrolled diabetes, all this causing conditions, or infections like torch infections, autoimmune disorders, teratogenic drug exposures should go with a fetal echo. Whereas in fetal indications are increased nuchal translucency, yes, high drops, abnormal fetal screen on antenatal scan, like regular anomalous scan showing some abnormality, is they need to go for fetal echo. Abnormal ductus venous waveforms, abnormal fetal karyotyping like syndromic babies or syndromic approach. Next, major cardiac and extracardiac anomalies. Extracardiac anomalies like ileal atresia, diaudinal atresia, extracardiac anomalies should go for a fetal echo. Persistent brady or tachycardia. So usually the fetal echo should be done between the 18 to 22 weeks of gestation. Next, clinical presentation. So clinical presentation or clinical examination, how do they present? Very few babies can be asymptomatic at birth, but critical congenital heart disease can be presented from birth to 2 weeks of duration. Like in case of a TOF with not a critical PS, tetralogy of Fallot with not a critical PS or very mild pulmonary stenosis can have presentation later in life. So all this can be presented from birth to the till 2 weeks of time. But most of the duct-dependent systemic circulation disorders will be presented at birth. So most of the left-sided obstructions. So there are two things we have classified into 4 categories. 1 is right side obstruction, left side obstruction, 3 is parallel, and 4 is complex. So right side obstruction, most of the left side obstructions will be presented at birth, whereas right side obstructions depends upon the obstruction at what level of obstruction we see in the pulmonary area. So in the presentations, so most can be asymptomatic at birth. And what are the other presentations could be? Tachypnea, cyanosis, shock, murmur, signs and symptoms of failure. So, so cyanosis we have already discussed, and tachypnea I'll be discussing later now, and shock, murmur, signs and symptoms of failure. Next. So, as I've told you, duct-dependent pulmonary blood flow, that is right side obstructions or TAPVC or TGA, they mostly predominantly presents with cyanosis, whereas tachypnea and murmur will be a second. Whereas in duct-dependent systemic blood flow, mostly they present with a shock, that is decreased blood flow, obviously. Left obstruction leads to shock. So shock, whereas cyanosis, tachypnea and murmur will be a second cause. So it first comes with it, as I told you, respiratory distress. So this is tachypnea or retractions. The main difference between the tachypnea and retraction, that is respiratory, is pulmonary causes. So when it is not improving, as our index case, which is not improving conventional respiratory support, we have started with SIMV, went to an HFO, high pressures. Even though it is not improving with the conventional respiratory support, then it should be indicating with of echocardiography. Then that's a most cause of heart disease or congenital heart disease. So any hypoxemia, yes. So pulmonary causes and cardiac cause. Cardiac cause, get an X-ray. In the X-ray, there is a decreased pulmonary blood flow, that is oligemic lung fields. Think of TOF with TS or tricuspid stenosis or tricuspid atresia with intact ventricular septum, Epstein's anomaly. Whereas normal blood flow is seen with the cardiac condition is DTJ and truncus arteriosus. So next thing is signs and symptoms of cardiac failure. Neonatal cardiac failure, they have more symptoms like tachypnea, tachycardia, cardiomegaly, hepatomegaly, pulmonary edema, decreased oliguria, that is decreased urine output, head sweating, irritability, feeding difficulty. These are the main features of signs and symptoms of cardiac failure. Next comes with the murmur. Do all murmurs need an urgent evaluations? Not all murmurs we have an urgent echocardiography. The few things like presented with murmur with signs of heart failure, yes. Pre and post ductal difference of saturations is urgent evaluation. Absent of femoral pulse or lower limb saturations, we have to get an urgent evaluation. If there is a loud murmur of more than 2 or diastolic murmur associated with dysmorphisms, then we need to evaluate the child, but not on an urgent basis. They should be evaluated before discharge. Next, bedside test. Bedside test number 1 is pulse oximetry. Very, very, very important and What is pulse oximetry test? We know pulse oximetry. What is pulse oximetry? It is useful to differentiate or identify the hypoxemia that is not visible clinically. If the hypoxemia is visible clinically, that is cyanosis. As we discussed previously, what is hypoxemia, which is visible clinically, is cyanosis. If it is visible clinically, yes, we'll go for it, obviously echocardiogram. Which is not visible like that, it is an early diagnosis. To maintain the early diagnosis of critical congenital disease, the pulse oximeter has been invited as come into a picture. That is, can also be differentiated, identify difference in pre and post ductal saturations. So pulse oximetry is, it's quick and easy and safe. So how do we do it? We connect it to the sensor to the palm of the right hand, and other sensor to the feet, any of the feet. Usually pulse oximetry tests should be done between the 24 and 48 hours of birth or before discharge. If the discharge is getting 24 before 24 hours, if the baby is getting discharged, yes, do it. Usual ideal time is between 24 and 48 hours. The main use of the main theme of the pulse oximetry was main targets, where the primary targets of screening are 7 conditions. That is HLHS, hypoplastic left heart syndrome, pulmonary atresia, tetralogy of Fallot, TAPVC, TGA, tricuspid atresia, and truncus arteriosus. This is the main targets. The primary 7 targets for the screening are this. And so next comes with the, yes, start with a screen. The screening is done. The screen and then so while screening, if the right hand or a foot, any of the saturations are less than 90%, then the screen is failed. No, don't even have a second thought. Send for the echocardiography. If the screen is between the 90 to 95% in right hand and foot, or more than 3% between the right hand and the foot, repeat after 1 hour. That is less than 90% in right hand or foot, or 90 to 95% in right hand and foot, or more than 3% difference between the right hand and the foot, repeat after 1 hour. So if it's less than 90%, yes, directly, even any of the time, the less than 90% of the any of the limb, just directly go for a failed screen, get an urgent echocardiography. If there is between 90 to 95%, repeat after 1 hour, even after the 90 to 95% after the 1 hour, and again repeat after 1 hour. Then even at that time, after two repeating of 2 hours, after 2 hour gap, then it will then go for a failed screen, get a conduction. Any other time, if it is more than 95% or less than 3% difference between right hand and the foot, then it is a fast test. Okay, we have it. We need to give a gap of 1 hour between the 2 screens. That's it. So more than 2 times, if you find between the 90 to 95%, then which called as a failed screen. So routine pulse oximetry screening. What are the pros and cons? Yes, we all know that early detection of congenital heart disease, early treatment, it will obviously decreases the mortality. Indeed, it will decrease detection of the other conditions like PPH1, early sepsis, or it's a low risk of harm or non-invasive method. It's a cost effective, easily done at the bedside. All this in the pros. What are the cons? Cons is false reassurance if negative screen. So if the screen is negative and still the baby is having a congenital heart disease, the false reassurance can be given. False positive is seen if the screen has been done within 12 hours of life. The false positives are seen. Parental and staff anxiety, like what are we doing if it is false positive, and if it is a then again we need to get instant echocardiography unnecessarily. All these things and anxiety of the staff or the parents. And then the pulse oximetry having an very having a good specificity, but a sensitivity levels around 76.5%. It's highly specific but moderately sensitive. Next comes with the how do we manage a critical congenital heart disease. Any critical congenital heart disease, first, like in all other any other cases, thermoneutral environment of the baby, maintain airway breathing and circulation, appropriate respiratory support, IV fluids, and initiation of prostaglandins. Irrespective of it, you can initiate the prostaglandins whether it is an obstructive disease or not initially if you have a suspicion of critical congenital heart disease. So as I have discussed, broadly classified into duct-dependent pulmonary blood flow, duct-dependent systemic blood flow. So primarily we'll discuss about first in a duct-dependent pulmonary blood flow. So what is duct-dependent pulmonary blood flow? So there is an obstruction in the right side. So obstruction blood flow to the pulmonary artery from the heart due to severely pulmonary stenosis or pulmonary atresia. PDA is the only source of blood flow. If there is a PDA is closed in that conditions, there is decreased blood flow to the pulmonary artery and lungs are underperfused. So oligemic lung fields are seen. The most common causes is right-sided obstructive lesions. What are the right-side obstructive lesions are? Tetralogy of Fallett's, all pulmonary or all pulmonary stenosis, all P. Pulmonary stenosis, like single ventricle with pulmonary stenosis, double outlet right ventricle with pulmonary stenosis, tetralogy of Fallett, pulmonary atresia with intract ventricular septum, pulmonary atresia with VSD, tricuspid atresia with pulmonary stenosis, severe Epstein's anomaly. So all these things present with a duct-dependent pulmonary blood flow. So how do we present? Yes, any right-side obstruction leads to a cyanosis. Yes, cyanosis, increased work of breathing, chest X-ray showing pulmonary oligemic lung fields. So any cyanotic baby with oligemia in chest X-ray, suspect of duct-dependent pulmonary lesions. That's it. So in a brief, we have only one thing we need to remember is cyanotic baby with oligemia in chest X-ray. Next, how do we manage? As I told you, we need to start at if there is a decrease in blood flow to the right side, decrease in blood flow to the pulmonary artery. Again, there will be oligemic lung fields and increase in work of breathing. All this. So to prevent, at least to increase the pulmonary blood flow, start prostaglandin even so that the PDA will be ductus will be patent, and then stabilize the infant until surgical intervention, assisted ventilation or increase environmental oxygen. Saturations can be adequate till 75 to 85% is accepted. So what is PGE1? We all know prostaglandin E1, that is the dose is 0.05 to 1 mg per kg per minute. And then maintenance has to be given. Usual maintenance dose is 0.01 to 0.025 mg per kg per minute. Once diluted, can be stable for about 24 hours. A response is seen within 10 to 15 minutes after starting of PGE1. Half-life of PGE1 is one full circulation, that is 14 to 15 seconds. That's why it should be a continuous infusion. It's not be like a dose wise. It should be a continuous infusion because the half-life is only about 14 to 15 seconds out of it. Complications is the prostaglandin complications are apnea, that is direct effect of PGN on the central nervous system. So, any apnea immediately after starting of PGN, if the child is having increase in requirement or assisted ventilation requirement immediately, then think about one of the side effect of PGE1. Hypotension, peripheral vasodilatation, decreased cardiac output. Continuous measurement of arterial blood pressure should be necessary in this case of starting with PGE1. Fever, irritability, diarrhea, hypertrophy of gastric mucosa, which is a long-term effect. So one of the very few things I'm going to discuss, not all, that is pulmonary atresia with intact septum. So so most of the comes here. What happens in pulmonary atresia? There is an obstruction in the pulmonary artery. So there is an outflow of the pulmonary outflow of the right ventricle. So this leads to right atrium will get dilated, and then the right ventricle will be hypoplastic. As this is the pulmonary outflow, there is an obstruction. There is so much use of the right ventricle, so right ventricle will get hypoplastic. Whereas right atrium, all the pressure develops here, so right atrium will be dilated, and there will be tricuspid regurgitation. The chest X-ray, yes, there is a low blood flow to the pulmonary artery, so there is a chest X-ray will show oligemic lung fields. So there will be a pulmonary, if there is a PDA present, if there is a PDA present between the aorta and the pulmonary artery, then there will be a left to right shunt. Then we can see a pulmonary plethoric lung fields. So next is duct-dependent systemic blood flow. How do duct-dependent systemic blood flow presentations? So now we have read about right side obstruction. Let's go with the left side obstruction. So duct-dependent systemic blood flow. Aortic outflow from the left ventricle is decreased. So if the PDA is there, this will shunt blood from the pulmonary artery to the aorta to maintain the systemic circulation. So there is a left heart outflow obstruction. So usually they present with a congenital obstructive left heart syndrome or left ventricular outflow tract. Will usually present in the first few weeks of life. As there is a duct-dependent systemic circulation become compromised with the closure of PDA, so they may present in the later of life also. So how do they present? As I have mentioned earlier, they present with a systemic hypoperfusion or shock. So how do we differentiate this shock from the normal other causes of cardiogenic shock? Cardiomegaly, low postductal saturations, which will usually differentiate between the other causes of shock from the caused due to congenital heart disease. So very, very important is cardiomegaly and low postductal saturation is one of the differentiating features between the other causes of shock and the shock due to critical congenital heart disease. The serial increasing in the blood levels this usually shows that what tissue oxygen there is a debit in the tissue oxygen, which indication that there is a low cardiac output, which indicates in per se indicates the severity of the heart disease. So the serial increasing in blood lactate levels, one of the things we need to think about is congenital cardiac disease. Those sepsis we usually we think, but one of the things we need to have in mind is critical congenital heart disease. Next, the low femoral pulsations, lower limb BP will be low. So what are the as I told you, cardiogenic shock. What are the features of cardiogenic shock? Hypotension, tachycardia, poor perfusion or dusky or motile perfusion, oliguria, acidosis, increase in lactate levels. What are the conditions? Aortic stenosis, coagulation of aorta, interruption of the aortic arch, HLHS, hypoplastic left heart syndrome. How do we manage with the left-sided obstruction of the heart? Is the same like thermoneutral environment, maintain the airway, place the patient in oxygen cardiopulmonary monitoring. So monitor the pre and post ductal pulse oximetry and blood pressure. IO axis, as usual, if there is a shock, usually what we do is we give a crystalloids, but if there you are thinking about cardiogenic shock, minimize the fluids. ECG and X-ray should be done as soon as possible. Maintain the glucose levels, ABG, blood culture has to be done. Because the main feature we think about is sepsis. So we need to have both the things. Next, hyperoxia test. Then go with the PGE1. So we have some conclusion. This is due to critical congenital heart disease. Then start with the PGE1. As we have already discussed, start with the PGE1 with a 0.05 to 0.1 mics per kg per minute IV route as a continuous infusion, and then get an echocardiography. Then comes with the diagnosis of whatever systemic obstructive disease we have seen. Next, parallel circulations. Parallel circulation, that is transposition of greater arteries. Next is complex lesions like total anomalous pulmonary venous connection or TAPVC with obstruction or truncus arteriosus. First comes with the transposition of great arteries, that is DTGA, text to TGA. So in this DTGA, we know that right atrium and right ventricle, the right side will be the same, left atrium and left ventricle will be the same. From the aorta, which is supposed to be onset from the left of the heart, will be arising from the right of the heart. Whereas pulmonary artery, which is supposed to arise from the right side of the heart, will be arising from the left side of the heart. So so this aorta will receive deoxygenated blood, go to the systemic circulations, and then again the systemic circulation will come to deoxygenated blood from the all part of the body, and then go to the right atrium, and then again right ventricle. Will be a parallel circulations. If there is no connection between the right and left side of the heart anywhere, like either in the form of a PDA or there is no ASD, there is no VASD, the early there will be an early presentation. Any of the connection between the right and the left are there, the presentation might be delayed. But if there is no connection between right and right, any of the in any of the septums like arterial septum or ventricular septum or PDA, the prognosis, the presentation will be very early. So, right ventricles, from the right ventricle, aorta is arising here. This is an aorta. So aorta taking a deoxygenated blood and supplying to the body, whereas all the pulmonary inferior vena cava and superior vena cava connection deoxygenated blood and supplying to the right atrium. So this circulation goes one way, and the other way, left atrium receiving the pulmonary veins from the lungs, oxygenated blood, and the oxygenated blood goes to the left ventricle. Again, this oxygenated blood will go to the lungs with a pulmonary artery. Here this is a PDA. If there is no PDA, if there is no PDA between this connection, as I mentioned earlier, the presentation will be absent of PDA. The presentation will be very, very, very early. If there is any of the connection is there, presentation will be late. So clinical manifestations were, as we know that congestive, they can present either as a cyanosis, tachypnea, same as respiratory distress, congestive heart failure. So ECG shows an right ventricular hypertrophy. So chest X-ray showing cardiomegaly, and if there is a connection, increase in pulmonary blood flow. Even though if there is no connection, the pulmonary blood flow will be increased. So plethoric lung fields. So X-ray was showing, X-ray shows egg on the string appearance. This is a string and this is an egg on the string appearance. How does this egg on the string appearance is due to mainly the convexity of the right border, right atrial border with a left atrial enlargement, while the superior mediastinum appears to be narrow due to the stress thymic atrophy with hyperinflated lung fields. That is plethoric lung fields are seen. So medical treatment, as all the critical congenital heart disease, that is starting of prostaglandins, and then the main treatment is balloon atrial septostomy. So both the arteries are switched. Material atrial septostomy is initially done. If there is no atrial septostomy, then there is no connection between the right and the left. So ballooning atrial septostomy is initial to be done and start on ionotropic and diuretics. The permanent, the main mode of surgical intervention is atrial switch operation, switching of the pulmonary to the right, pulmonary to the right, and to the aorta to the left. Switching is the main mode of surgical management. The complex lesions is TAPVC. What is TAPVC? Total anomalous pulmonary venous connection is, or APVR, is a congenital heart disease in which all the pulmonary veins fail to make their, normally all the pulmonary veins connected to the left atrium. But in this, they fail to make their connection to the normal connection to the left atrium. So where do they drain? If they are not draining to the left atrium, they have to drain somewhere. So this result in drainage of all pulmonary venous into the systemic venous circulation. Systemic venous circulation, that is, they are draining into the right atrium. So either they are draining into the right atrium. So how do they drain with the right atrium? So either by they are divided into 4 types. That is supracardiac, cardiac, infracardiac, and mixed. So supracardiac, all these pulmonary veins in both the lungs, they form a confluent chamber that is located just posterior to the left atrium. From this chamber, blood moves vertically to a oriented vein that most often connects to the left innominate vein. So the other connections with supracardiac TAPVC, they also can be connected into superior vena cava, azygous vein, persistent left superior vena cava, all this. So any of the pulmonary venous connections connected to the right atrium, either by all these veins, either by superior vena cava or to the azygous vein, or the persistent of left superior vena cava, or through a left innominate vein which indirectly connected to the left atrium. So they are going to the left atrium. Next, cardiac wise, yes, they're directly connected to the right atrium, but not directly. They form a so towards the heart, but instead of normal leakage within the left atrium, the pulmonary veins connect to the posterior aspect of the coronary sinus or to the right atrium directly. Infracardiac TAPVC results from the retained pulmonary venous connection to the umbilicovitellian venous system, or the pulmonary veins drains a common vertical vein that is causing inferiorly from the mediastinum, either to the diaphragm via esophageal hiatus, or inserts most often the portal vein, other venous like hepatic vein, ductus venous system, inferior vena cava. Any of this, inferiorly they connected to the inferior vena cava or ductus venous system, and then they go back to the right atrium. So ultimately, it is joining it to the right atrium. So this is supracardiac, where they're connecting it to the above the above the right atrium, whereas this is a cardiac type, where is it connected directly to the right atrium. This is and this is one of the cardiac type, and this is the other cardiac type. Infracardiac, so somewhere down near the inferior vena cava, it is forming with the ductus venosus and connecting to the inferior vena cava. This is a mixed. So what is physiology? So from the base we have understood. So anything, anywhere like supracardiac, cardiac, or infracardiac, the pulmonary venous is connected to the right. So pulmonary veins are connected to the right atrium indirectly or directly. So all the blood flow from the pulmonary veins, that is all the oxidative blood from the pulmonary veins, they enter into the right atrium. So in patients with TAPVC, the entire oxygenated pulmonary venous return mixes with the deoxygenated blood from the systemic venous system. So they mix. In supracardiac, infracardiac TAPVC, mixing the blood occurs where the pulmonary veins join to systemic veins before returning up the heart, whereas cardiac type just adjacent to the right atrium. So this mixing permanently leads to partially oxygenated blood. So this will leads to they will mix the blood with the right atrium. So right atrium already had a deoxygenated blood. So this partially oxygenated blood is then shunted to the so oxygenated blood and deoxygenated blood both mix. Then leads to a partially oxygenated blood, which then shunted to the right to left at the atrial level into the systemic circulation, resulting in cyanosis. Because the right atrium is receiving blood from both pulmonary and systemic venous system, both the right atrium and the ventricles become dilated. So what happens if this pulmonary venous system gets obstructed? Significant obstruction in the pulmonary venous related to the heart. This leads to pulmonary venous pressure will get raised and the high pressure is transmitted to the lung vasculature. Backflow. This is the back. So pulmonary venous pressure is high. So pulmonary pressure is transmitted to the lung vasculature, in turn resulting in the progressive interstitial and alveolar edema. These changes in turn lead to increased pulmonary vascular resistance and elevated pulmonary, so backflow. So everything happens back. So pulmonary venous pressure is high, lung vasculature increases, resulting in pulmonary interstitial and alveolar edema. Then back. So we were going back. So lead to the increased pulmonary vascular resistance and elevated pulmonary artery pressure. So pulmonary artery pressure can exceed this pulmonary artery pressure is higher than the systemic pressure, resulting in right ventricular dilatation, hypertrophy, and right heart failure. So what is the treatment for in TAPVC? Start with TABC. So supplement oxygen, mechanical ventilation, inotropic support, palliative cardiac catheterization. So initially to temporize this, so the obstruction has to be reloaded. So temporary cardiac catheterization procedure include arterial septostomy in patients with restrictive intra-arterial blood flow and stent placements in severely obstructed pulmonary and common vertical veins. So there is stent placement happens. Then the goal of the actual surgery happens. That is the goal of surgery is to re-establish direct pathway between the pulmonary veins into the left atrium. That is supra and infracardiac TAPVC with a common vertical vein. A normal pulmonary venous pathway is created artificially, and this opening is made anastomosis with the left atrium. In case of vertical vein is then ligated and divided. So ultimately they make the pulmonary vein, they make a chamber like pulmonary venous pathway chamber, which is then connected to the left atrium directly. So in our case, we have made an emergency stent placement, shifted to a cardiac center where they have placed an emergency stent placement in the obstructed level through umbilical vein, which was done in the next day, and the corrective surgery has been planned after 1 month. And the take-home message is critical congenital heart disease, early diagnosis and early intervention decreases the mortality and morbidity. So either from the antenatal fetal echo, very, very important, which has to be done for all, whatever the indication which we have mentioned. Next thing is, this is the thing, this only, if we carry this only line through my talk, that is then I have reached some level. Because pulse oximetry is it is an easy and bedside technique which will diagnose most of our critical congenital heart disease. So make all the babies compulsory compulsory pulse oximetry screening has to be done before discharge. And if we suspect a critical congenital heart disease intrauterine, transport intrauterine, then postpartum, because it again delays the diagnosis and treatment, early diagnosis and intervention. Thank you.
Thank you, Dr. Sindhu, for wonderful and crisp presentation. And there is one suggestion by Dr. Anjali. She wanted to see you. So just manage your camera once again. Dr. Abhishek Agarwal has a question. Do we do hyperoxia test nowadays or are they omitted?
If we clearly want to diagnose it in a clinical aspect, yes, do a hyperoxia test. Yes, it is done in a teaching hospitals. I mean, though it is, yes, it is done. It is completely, yes, it is very, very useful test to, if we don't have a bedside echo, we don't have a cardiologist at our center nearby, or it will take some time in level 2 areas and all, then definitely hyperoxia test will help us. Like, see, in my case only, if we don't, we have done hyperoxia test and we have given 2 doses of surfactant, though RDS could be the one of the part of it, but we could have omitted 1 dose of surfactant if we would have diagnosed early. So, so this way, hyperoxia test definitely help us.
What is the maximum age we can use prostaglandins?
Neonate, till as per my knowledge, it will till about 2 months. I am sure we can use 2 to 3 months. To the max, more than that, I'm not sure. I'll just let you know. I will recheck it out. But till my experience, I have. Sorry, sir. Someone is talking.
I was just suggesting that if we will get back with the correct answer to that question, and we will revert back.
Yes, I'll just put in the group. I will recheck with the evidence and put in the group.
Yes. I think there is no other question. Anyone, any other question? You can use the chat room to put your question.
You can use the group also to put. If anything, I can add on in that also. If you have, I mean, after this
That
session also, if
seems
you have any
very
doubts,
central.
please.
If somebody has any comment, they can unmute themselves now.